Okay, good evening, everyone. So today we're going to do little bit of talk on complete spectral Doppler and also some miscellaneous echocardiography. So I think this is important for especially for people that go for echo board, because there's really going to be a lot of question based on mode and spectral Doppler that they expect you to diagnose. The good thing about mode and spectral Doppler is people thought that it is difficult. But once you remember all types of mode and spectral Doppler, actually this is actually quite something that you can easily get points for when you go for exam. So basically the format of this talk is question and answer, but because for convenience sake, I will answer the question, but at the same time, I will explain to you the thought process behind it, okay? So this is the first question. So this is a typical question in exam, okay? So sometimes they can just give you a typical Doppler flow like this, okay? See, this is a Doppler across the aorta, all right? And the blood pressure is 150/80, okay? And then they will ask you to guess or to calculate the number inside a certain cardiac chamber. So in this situation, they ask you what is the pressure inside the LV by giving you the Doppler across the aortic valve. So you have to recognize what does the Doppler across the aortic valve shows you. So this is actually a continuous wave Doppler, so CW Doppler. So what's the difference between CW Doppler and PW Doppler? So the difference between CW Doppler is the CW Doppler is used for you to measure the highest velocity across the insonating beam. So let's say your beam of ultrasound here, the CW Doppler will measure the highest speed along this line. So doesn't matter, no matter where you put your Doppler. So even if you put your Doppler there, it will measure if the highest velocity is here. Okay, so that is continuous wave Doppler. Pulse wave Doppler is very range specific, meaning that in pulse wave Doppler, you wanted to measure the velocity at a specific site. In continuous wave Doppler, you cannot really tell where are you measuring the highest velocity, okay? So it can be at any place along the line here. In pulse wave, if you put that is the place that the velocity is measured, okay? So what is the advantage of PW or pulse wave Doppler? The advantage is you can measure at a specific place what is the velocity. What is the disadvantage of PW Doppler? It is aliasing. PW Doppler cannot measure normally a velocity above 1.5 meter per second. So any velocity that you above 1.5 meter per second, you will see aliasing in your Doppler, so you cannot measure. So whenever you want to measure something that is above 1.5 meter per second, you have to use continuous wave Doppler, okay? So like this patient, you can see that it's 4 meter per second, so you cannot use pulse wave Doppler for this situation, okay? Another thing that you have to understand from Doppler is, so when you see this, synchronized with the cardiac cycle. So this is in diastolic, so this is systolic. So meaning here to say at systolic, the difference in pressure between the left ventricle and the aorta, okay, the difference in velocity between the left ventricle in aorta is 4 meter per second. But this is velocity. In order for us to change to pressure, you have to use the Bernoulli equation, which is 4V squared. So 4 times 4 times 4. That is 64 millimeter mercury. So the instantaneous pressure difference between the LV systolic pressure and the aortic systolic pressure based on this Doppler is 64 millimeter mercury. Okay. The diastolic pressure difference is also the same. You can see it is also 64 millimeter mercury, but you have to understand that this is the difference between the aortic diastolic pressure and the LV diastolic pressure. Okay, aortic diastolic pressure and the LV diastolic pressure is 64 millimeter mercury, because this is the pressure difference between aorta and the left ventricle, because this is aortic regurgitation. Okay. So how do we know the LV pressure? So I show you the equation first, okay? Okay, the answer is 195/16. So how do we get the answer 195/16? You can see that the peak instantaneous gradient between the LV and the aorta is 64 millimeter mercury, okay? Now, that is the peak instantaneous gradient. because you are measuring the BP you use with cuff in the aorta, so what you want is not the peak instantaneous gradient, but the peak to peak gradient, okay? The peak in the left ventricle and also the peak in the aorta. So you have to use, normally, peak to peak gradient is 70% of peak instantaneous gradient. So peak to peak gradient is 70% times 64, which is 44.8 millimeter mercury. So LV systolic pressure minus aortic systolic pressure, so that is your gradient here, equal 44.8 millimeter mercury. Therefore, LV systolic pressure is equal to the aortic systolic pressure 150, the one that you have here, plus 44.8, so that is 194.8 millimeter mercury. So that is why the systolic is 195. So what about the diastolic? So remember, this is the difference in pressure between the aorta during diastole and the left ventricle during diastole. So therefore, aortic diastolic pressure minus the LV diastolic pressure is equal to 64 millimeter mercury. Okay, that we just rearrange the equation. LV diastolic pressure is equal to 80, which is the diastolic aortic pressure, minus 64, which is 16 millimeter mercury. So as you can see, we can get the answer 195 over 16. Okay, so that's how we calculate. So whenever you see Doppler, always think this gradient is the difference between which chamber and which chamber. Okay, this is between LV and aorta. Okay, and this is between aorta and LV. This is during systole, and this is during diastole. So that's how you measure it. So a lot of this is a favorite exam question, okay, about aortic pressure. So there's a certain salient point, okay. Number one, peak instantaneous gradient in echo is always higher than peak to peak gradient in catheter. So what do I mean? We go back to the previous echo. So if you can see here, so the red one, this is the aortic pressure. The black one, this is the left ventricular pressure, okay? So what echo measure is peak instantaneous pressure. So not the peak LV and the peak aortic pressure. It doesn't measure the difference between that, okay? It measures peak instantaneous pressure, meaning that the time along this area in which the difference between this and this is the highest, okay? But when you use catheter, so if you use a catheter, one in the left ventricle and one in the aorta, what you are measuring is peak to peak, meaning that the highest gradient in the LV pressure here and the highest gradient in the aortic pressure here, and then you minus the two, okay? So peak instantaneous gradient, because it is the biggest distance between these two, is always higher than peak to peak gradient, okay? So I will repeat one more time. The peak instantaneous gradient in echo is always higher than peak to peak gradient in catheter. Okay, now if you want to do calculation, if let's say they only give you the aortic pressure, so that what you can get is only peak to peak, how to change peak to peak instantaneous? So very easy. Peak to peak gradient is 70% of peak instantaneous gradient. If you see that my calculation before, I know that the peak instantaneous gradient between the LV and aorta is 64 millimeter mercury, okay? But they're giving me systolic of 150, right? So I have to change this peak instantaneous gradient to peak. So I do 70% times 64, which is 44.8 millimeter mercury. Diastolic pressure is not affected by this different measurement, okay? So the diastolic pressure is the same, whether you measure it from using catheter or you measure it using Doppler. Right, so this is a favorite question, right? Now, mean gradient, okay? Mean gradient that you measure in echo should be the same with mean gradient that you get using catheter, unless there is pressure recovery. So when you have significant pressure recovery, the mean catheter that you measure, the mean gradient that you measure with catheter is lower than by echo. All right. So in which situation that we have pressure recovery, it is happen in usually two situations. Number one is small metallic valve. Usually the size is 19 or 21 millimeter, or small ascending aorta, less than 3 centimeter. Okay, what does pressure recovery means? So let's say you have LV pressure of 100 millimeter mercury. Okay, so across the aorta, all right, suddenly you measure using the echo, you got a gradient of, for example, 40 millimeter mercury. So across aorta, you got 60, 100 minus 60, so 40 millimeter mercury. However, when you measure with catheter, okay, you notice that the pressure difference has now come down to 30. So at first, okay, so let me just give you some example. So let's say this is the aorta. Okay, so that is the valve there. All right. Now, if you measure with echo, you measure somewhere very near to the valve. If you measure the with catheter, you measure somewhere here, far. Okay. Now, let's say you measure here, you got a pressure that is 100, let's say 100 millimeter mercury. Okay. So that is pressure inside the left ventricle, right? Now, if you measure inside here with echo, it might be 70 millimeter mercury. Okay. So what is the difference between 100 and 70? So that will be 30 millimeter mercury. Okay. So that will be the gradient you measure between the left ventricle and aortic valve after the aortic valve with echo. And the difference is only 30 millimeter mercury, right? Now, if you have a small bileaflet valve or small ascending aorta, this 70 millimeter mercury, if you measure here, will no longer be 70. Okay, it will go up some more. Okay, so let's say you measure and then here it become, for example, 80. Okay, so the gradient that you measure is 100 over 80, so that will be 20 there. Right now, so the mean gradient that you measure with echo is 100 minus 70, which is 30. The mean gradient that you measure with catheter is 180, so the difference is 20. So you measure with echo is 30, you measure with catheter, it is 20. All right. So why is that so? So how come the mean gradient is not the same? So the reason is the small valve or small ascending aorta. So the potential energy here recovered from 70 millimeter mercury just distal to aortic valve. Now it has recovered. It has gained an extra 10 millimeter mercury when it travels to the distal ascending aorta. So that the mean gradient has become lower. So this is mean gradient with echo. This is the mean gradient with catheter. And this is the pressure recovery, 70 to 80. So this recovered 10 millimeter mercury of pressure from here to here. Okay, so I hope you understand that now. All right, so sometimes in echo exam, they also will give you hemodynamics, okay? So this is a hemodynamics, okay? And let's say that this is a wedge pressure, okay? So what is a wedge pressure? So wedge pressure is inside the left atrium, okay? Now, you have to recognize, okay, what is this kind of wave? What is this wave here, okay? So this is actually a V wave, okay? This is a giant V wave. So you have to recognize what is giant V wave. So giant V wave, if you see it in the left atrium, that means significant mitral regurgitation. If you see giant V wave in the right atrium, that is significant tricuspid regurgitation. Okay, so this is important. Okay, because you have to remember the wave, different waveform inside the atrium. Okay, so the A wave, the C wave, the X descent, the Y wave, and that also the V wave. Okay, so this is a giant V wave. And another thing, if you look at the Doppler across the mitral valve here, you look at the E velocity. The E velocity is way above 1.2 meter per second. Okay, so if you are dealing with mitral regurgitation, one of marker of significant mitral regurgitation is a path wave Doppler across the mitral valve in which the E velocity is more than 1.2 meters per second. Okay, always be suspicious whenever you see E velocity across mitral valve that is more than 1.2 meter per second. That shows you the patient having severe mitral regurgitation. Okay, so the question is like this. So this is a 65 years old patient with mitral valve prolapse and mitral regurgitation. Okay, so the question is, based on this Doppler here, and based on this pulmonary venous pattern here, what do you think is the mitral severe, the correct explanation. Number one, he has a normal diastolic function. Number two, the MR is probably not very significant. Number three, the MR is likely to be at least moderate to severe. Number four, cannot tell with certainty. Okay, so the answer here is the mitral regurgitation is at least moderate to severe. So how do I know this? So I know this because I know that in severe mitral regurgitation, the E velocity across the mitral valve will be more than 1.2 meter per second normally. Okay, how do I know the other one? Look at this pulmonary venous flow. Synchronized with the diastolic, so that is diastolic there. Okay, so look from here to here, that is systolic. Okay, look, you have a systolic reversal. Normal Doppler should be like this, systolic, like that, diastolic. Okay, and then you have the atrial contraction. Here you can see you have a systolic reversal. Systolic reversal. Remember, systolic reversal in pulmonary vein is a specific sign of severe mitral regurgitation. So you have one, E velocity more than 1.2, two, systolic reversal in pulmonary vein, three, V wave, giant V wave in the wedge pressure. So this is all consistent with significant mitral regurgitation. Okay. So you can get that just from the Doppler profile here. Okay. I just wanted to give you tips. When you do transesophageal echocardiogram, if you want to look for pulmonary vein reversal, okay, don't measure in the pulmonary vein in which the jet of the mitral valve impinge on. Okay, sometimes if you have eccentric jet, you know you have 4 pulmonary vein, right? So the jet might go into one of the 4 pulmonary vein. If you measure in that pulmonary vein, you will always see pulmonary reversal, systolic pulmonary reversal. Don't measure that. Measure on the other pulmonary vein. Okay. All right. Now, this is a TEE, and then they pulse inside the left upper pulmonary vein. Okay, so in TEE, you can see this. Okay, this is the systolic flow. This is a diastolic flow on the pulmonary vein. So they're asking you which flow here is due to atrial relaxation. Okay, pulmonary vein, when we pulse, if you look here, there is no systolic reversal. So this is systolic. The systolic are all forward flow. Okay, there is no reversal, right? So which one is due to atrial relaxation? So in order to know this, we have to know the different waveform of the left atrium. Okay, so you have to know your A wave, your atrial contraction, your C wave, your X wave, your V wave, and also your Y descent, right? So the answer is, in this situation, so I just show you all the text. So the answer is A. So this is actually the atrial relaxation. So let's go one by one. Okay. So the mnemonic that I wanted to teach you to remember, and this mnemonic is very stupid. Okay, but somehow I can remember based on this mnemonic. Okay. So this stupid mnemonic is called Anderson Cooper Love Vanderbilt Yale. Okay, this is a name of American newscaster. And this is the name of American philanthropist. Okay, so that is A. C, Love is X, Vanderbilt is V, and Yale is Y. So let's go by one. Okay, what is A? So A is N diastole, which is atrial contraction. Okay, what is C? So C is the very beginning of systole, when the tricuspid valve move upwards into the left atrium or into the right atrium. Okay. What is X? So X is at early systole, which is called X descent. Okay, at early systole, when the atrium is relaxing, okay, and start receiving blood from the pulmonary vein. Okay, so atrial contraction is N diastole. C wave is early systole. X wave is X descent is also early systole when the atrial is relaxing and start to receive blood from the pulmonary vein. So that is X descent there. Okay. Now, what about V wave? V wave is N systole. So V wave is when the pulmonary vein is giving blood to the left atrium and at the end of that period. So therefore, if you have mitral regurgitation, it competes. So you have a blood that flow from the left ventricle to left atrium. You also have a blood that's flowing from the pulmonary vein to the left atrium. So therefore, you get this giant V wave if you have mitral regurgitation or tricuspid regurgitation. Now, why this is wide descent? This is at early diastole when the mitral valve open and the blood flow from the left atrium to the left ventricle very fast. Okay, so one more time, stupid mnemonic to remember this wave in the left atrium and right atrium. So the mnemonic is Anderson, Cooper, Love, Van der Wijk, Yale. A, so atrial contraction. C, so this is a C wave. X descent at early systole. V, this is a V wave at end systole. Y, this is Y descent at early diastole. So a giant V wave is a marker of significant mitral or tricuspid regurgitation. Okay, so just wanted to show you a normal pulmonary vein pattern. So this is a normal pattern during systole. Sometimes you can see two waves separating during systole. Sometimes you can see a single wave during systole, and that is diastole. This is atrial reversal. Okay, it is important for you to familiarize with pulmonary vein Doppler. Why is it important? Because this is important in diastolic assessment as well. So in diastolic assessment, once your diastology become worse and worse, the duration of atrial reversal become longer and longer. So this become longer and longer. Okay, so if it becomes significant when you measure the duration of pulmonary vein reversal minus the duration of mitral valve A wave is more than 30 milliseconds. Okay, so pulmonary vein A reversal minus mitral valve A duration, if it's more than 30 milliseconds, that is significant for diastolic dysfunction, right? So that is pulmonary vein. Okay, so let's look at question number 4. So they give you a Doppler here. So this is a Doppler across pulmonary valve. So whenever you have a question and they show you a Doppler, make sure you know where is the Doppler. So there is 3 Doppler here. So this is an M mode across pulmonary valve. So that is the M mode across the pulmonary valve. This is the pulse wave Doppler across the pulmonary valve. This is the continuous wave Doppler across the pulmonary valve. So the question here, what is your diagnosis? Is this pulmonary stenosis? Is this hypertrophic obstructive cardiomyopathy? Is this aortic stenosis? Is this pulmonary hypertension? Okay, so straight away from the question, you can rule out hypertrophic cardiomyopathy and aortic stenosis because this is flow across the pulmonary valve. Okay, so the only reasonable answer is between pulmonary stenosis and pulmonary hypertension. Okay, so which one is this? So this one is not so clear. So this is supposed to show you the flying W sign of pulmonary hypertension. Okay, I will talk a little bit about that later. So let's look here first. If you look at this pulmonary wave Doppler across the pulmonary valve, you can see there is notching here. Now, across the pulmonary valve, it should be parabolic like this. Okay, but here you see there is a notching right here. That is the notching there. So that notching is a marker of pulmonary hypertension. Okay, so that is one clue. What is the other clue? Look at this. Look at this diastolic pressure. It is actually quite high. It doesn't go all the way down. Okay, it doesn't go all the way down, meaning that it cannot equalize with pulmonary. It cannot equalize with the pulmonary artery pressure. So this is a also marker of pulmonary hypertension. So now you have 2 marker of pulmonary hypertension, notching and the pulmonary wave Doppler during diastole that doesn't go all the way down here. All right. Now this is a flying W sign. Actually, you cannot see it here because I think the picture resolution is not good. So if you put your M mode across a single pulmonary valve, sometimes you can see something that look like this. Okay. Okay, that look like that. Okay. So that is the flying W across the pulmonary valve. So this is M mode. This is pulse wave Doppler. This is continuous wave Doppler, and all of these are consistent with pulmonary hypertension. Okay, I will show you in the slide after this a clearer example. Okay, so this is what I wanted to show you. Now, if you put one MOT across a single pulmonary valve leaflet, you can see a few shapes. So in a normal patient, you can see that there is the shape in the MOT. Okay, so this is a normal shape. As you can see, because during end of diastole, the pressure inside the right ventricle is almost the same as the pressure inside the pulmonary artery. During atrial contraction, you can see a little bit of movement of the pulmonary valve. Okay, so that is normal. Now this is the flying W of pulmonary hypertension in MOT across the pulmonary valve. So that is your W. Okay, the one thing that you can see here, at the end of diastole, there is no movement of the pulmonary valve. What's the reason? So the reason is the pulmonary artery pressure is so high, such as at the end of diastole, there is a distance or there is a difference between the RV and pulmonary artery pressure. So whenever you have your atrial contraction, it doesn't affect the pulmonary valve. Okay, so therefore you don't see anything here, and then you see the flying W sign of pulmonary hypertension. In pulmonary stenosis is different. Remember, pulmonary stenosis usually is protective against pulmonary hypertension. So you can see that you have something that look a little bit different. You can see that the initial part is smaller than the later part compared to pulmonary hypertension, in which the initial part is bigger than the later part. Okay, so this is the flying W sign of pulmonary hypertension. So you have pulmonary notching by pulse wave, flying W by MOT, okay, and sometimes in continuous wave Doppler, you can see higher diastolic ending of that regurgitation flow. Right. If you have any question, you can ask me at the end. All right. So another thing that you can do, remember when you wanted to measure pulmonary hypertension, right? Normally you use the peak tricuspid regurgitation gradient. But in some people, you cannot get that TR. So what can you do? You can also look at pulmonary regurgitation, because that will give you mean PAP and also diastolic pulmonary artery pressure. Now, another way that you can do is use the pulse wave Doppler across the pulmonary valve. Then you can measure from the beginning to the peak. Then you can look at acceleration time. The shorter the acceleration time, the more likely the patient to have pulmonary hypertension. Okay. In fact, there is a formula to calculate this. Okay. So this is one of the formula. If you don't have TR or you don't have PR, you can use this formula. Mean gradient is equal to 79 minus in bracket 0.45 times acceleration time. Okay. Another thing, if you do not want to use this calculation, if you look at your acceleration time, okay, this is acceleration time from the beginning to the peak. If it is less than 90 milliseconds, then meaning that very specific that you have pulmonary hypertension. If it's more than 120 milliseconds, it is very specific that you have normal pulmonary artery pressure. Okay. So that is pulmonary hypertension. So I hope you familiarize yourself with what is the appearance of Doppler in patient with pulmonary hypertension. So next we go to a next MOT. Okay. So this is MOT of patient with mitral stenosis, another favorite in board exam. Okay. So what do we see here at the beginning? All right. You have to recognize that this is a typical pattern of opening of mitral valve when you do MOT. Okay. So that is anterior mitral valve leaflet. Okay. Going up at early diastole, then go down again, then go up again at end diastole, then only it close. If you look at the back, at the posterior leaflet, usually the posterior leaflet will go opposite of the anterior leaflet. So it will go down, go up here, and then go down back. So this posterior will go opposite of the anterior leaflet. Okay. Now you look what happened here. First thing that you can see happen is you can see that this slope here, the EF slope, has actually become much less steep. So it is very steep here. It become much less steep there. Okay, that is one sign of significant mitral stenosis. That is number one. Number two, look at the anterior leaflet here. It is thin. Okay, look at this anterior leaflet, the black thing. It is very thick. Okay, so this is another example of mitral stenosis. What is the next one? Look at the posterior leaflet. Remember, posterior leaflet should go opposite to the anterior leaflet in rheumatic mitral stenosis. In this situation, you can see the posterior leaflet is actually following the movement of anterior leaflet. Okay, so 3 summaries. The EF slope is less steep, the leaflet is thickened, the posterior leaflet is following the anterior leaflet. So this is an example of MOD of rheumatic mitral stenosis. Okay. So due to commissural fission, the PMVL goes the same direction of AMVL rather than opposite as in normal. All right. So what about this one? Okay. So this is an example of mitral valve prolapse. Okay. Let's look in detail. So this is the mitral valve in diastole. So this is a normal anterior movement of the mitral valve, anterior. You can see the movement of posterior valve, which is opposite to the movement of the anterior mitral valve leaflet. So you can see that it closed here, right? You can see that it closed there. So you can see the mitral valve closed here, but you can see suddenly it's sag. You can see suddenly it's sagging. Rather than continue to be straight, it's sag. Okay, so this is the part where it is prolapsing. Okay, now the more time during systole it is prolapsing, the more severe the mitral regurgitation. If you see here, it actually closed at the beginning and only prolapse at the end. Okay, so at the earlier stage of mitral valve prolapse, you hear this end systolic murmur, and you have this what they call a click and murmur syndrome. Click at the beginning when the chordae tendineae become taut, murmur at the end when you have the prolapse. Okay, so this is a very typical example of mitral valve prolapse. And from this M mode, you can also make sense the syndrome of click murmur and how severe is your mitral regurgitation. The more in systole the prolapse happen, the more severe is the mitral regurgitation. So this is the click, and that is the murmur, the click murmur symptoms of mitral valve prolapse. All right. So what about this M mode? Right now, if you look at this M mode, you can see that again this is mitral valve. So the mitral valve is doing well, opening and closing as normal. Okay. However, look at this interventricular septum here. So this interventricular septum is thick. You can see that the interventricular septum is thicker than the posterior wall here. So this is the interventricular septum. This is the inferolateral wall. This is much thicker. So you have asymmetric left ventricular wall thickening. So what is the differential diagnosis of asymmetric left ventricular wall thickening? So one of the most common diagnoses is, of course, hypertrophic obstructive cardiomyopathy. So how do I know this is obstructive? Look at during the mitral valve close here. Okay, as the mitral valve close, so this is the anterior mitral valve leaflet. You can see that the anterior mitral valve leaflet go towards the interventricular septum. In fact, at this bit here, you can see that it touches interventricular septum. This is left ventricular outflow tract, so you have dynamic left ventricular outflow tract obstruction because of SAM that is shown in the M mode here. One of the things that is very important is you can depend on the length of when it's touch the interventricular septum, how long it touch the interventricular septum. The longer it touch the interventricular septum, the more severe your outflow tract obstruction. Okay, the longer it touch, the more severe your outflow tract obstruction. So you have to recognize that this is a possible appearance of HOCM with SAM. Remember also that SAM doesn't only happen in HOCM. It can also happen in many other situations. Example, patient with hypertension, patient with aortic stenosis, patient with Takotsubo cardiomyopathy, patient with apical infarct. Okay, it can happen in many different situations, but most common situation in hypertrophic obstructive cardiomyopathy. So this is across mitral valve. What about across aortic valve? Is there any significant finding? Yes. In HOCM, if you look across the aortic valve, there is mid-systolic closure. Okay, what do I mean by mid-systolic closure? So this is the whole of systole. All right. Now it should close there at end systole, but it doesn't. It closed there at mid-systole. Okay. So that is very typical of dynamic outflow tract obstruction because of HOCM. Okay. So what is the reason? So the reason is you have your ejection first, but just at the end, because of the time you have a contact here, you don't have any flow. So therefore, your aortic valve closed at mid-systole. That is very important to differentiate from subaortic stenosis. In subaortic stenosis, they straight away close. Okay, straight away close. In this one, it closed at the mid segment. All right. So that's another thing that I wanted to tell you in this. All right. So the other thing, so whenever you have sub-aortic obstruction, sometimes you can see fluttering of the aortic valve in the M1. Okay, you can see fluttering. Whenever you see fluttering of the aortic valve, it is never obstruction at the aortic valve itself. So remember that aortic leaflet that is calcified cannot flutter. Okay, if the aortic valve flutter, meaning that the obstruction is below the aortic valve leaflet, right? So that is SAM there, and there's a mid-systolic AV closure of hypertrophic obstructive cardiomyopathy, right? Now, this is another M mode, okay? So this is a left ventricle, this is right ventricle. So what is this, okay? Now, how do I know that this is atrial septal defect? Then of course, atrial septal defect, I cannot know just looking by this M mode, but I know what is the pathologic situation that's happened. Look, the right ventricle is bigger than the left ventricle. Right ventricle is bigger than the left ventricle. So what is the differential diagnosis when right ventricle is larger than left ventricle? So either this is a pressure overload or this is a volume overload. Okay, so how do I know whether this is pressure overload or volume overload? Okay, remember that in pressure overload, this interventricular septum, okay, will be flat in either systole or diastole. Okay, sorry, either systole or diastole. So it will be flat in patient with pressure overload. But in this situation, you can see during systole, okay, when it should go down like this. So this is systole, this is the basal infralateral wall, go like that. The interventricular septum should also go like that, right? During systole. But you can see in this situation, the interventricular septum actually go the other way. Okay. Then during the systole, during the diastole is slightly flattened. Then during the diastole, it go the other side. During systole, it's slightly flattened. During diastole, it goes the other side. So this is paradoxical septal motion because of right-sided volume overload. So this is a paradoxical septal motion. Why paradoxical? Because during diastole, it should be rounded like this. But in this patient, sorry, during diastole, during systole, it should be rounded like this. But it go the other way. And during diastole, it is flattening. So this is right-sided volume overload. So we know that right-sided volume overload, one of the cause is atrial septal defect. Okay. Systole rounded and diastole flat. Okay. Now, this is an echo of someone with effective endocarditis and shock. So what is the best treatment for this patient? Okay. So they show you that this is anterior mitral valve leaflet. Okay. So you know that this is M mode across mitral valve. Okay. So what is the best treatment here? So what is happening here? So I just wanted to tell you what is happening here. Now, if you look, you always look at the ECG. Now, if you look at the ECG, so that is end diastole at the ECG. Okay. Now, here is early diastole. Look what happened on the mitral valve. So this is the period when mitral valve open, and look at mitral valve. It closed very early. Okay, closed very early. Diastolic haven't finished, but mitral valve already closed. Okay, so what can this be to? So this is because of very high left ventricle diastolic pressure. If you have a significant aortic regurgitation, like very severe aortic regurgitation, you have very high left ventricular end diastolic pressure. If you have high left ventricular end diastolic pressure, at diastole, even before diastolic end, your mitral valve has already closed. Okay, so that's why in patient with severe aortic regurgitation, sometimes you can see diastolic MR at the end of diastole. Okay, so what you can see in this picture here is premature closure of the mitral valve. So you can say that the mitral valve is actually the aortic regurgitation is actually very, very severe. So therefore, the answer for this question is aortic valve replacement, because this M mode show very severe aortic regurgitation. What other thing that you can see? You can see a shaggy line here. You can see the shaggy line here across the left ventricular outflow tract. So that is actually a vegetation that go into the LVOT and out of the LVOT during cardiac cycle. So this is a severe aortic regurgitation. So the answer is aortic valve replacement. All right. Now, why do patients have premature mitral valve closure? And patient also can have another one, premature aortic valve opening. Okay, let's look at the hemodynamics. All right. Now, this blue line is your aortic pressure. This yellow line is your ventricular pressure. Now, if you notice, during diastole, the left ventricular pressure is not going all the way down because of severe aortic regurgitation. Right. You look at here. Okay. Now, before, right? So if you look at the pressure inside the left ventricle, before end of diastole, the left ventricular pressure has already go above the left atrial pressure. Before end diastole, the left ventricular pressure has already go above left atrial pressure. So therefore, you get early diastolic mitral valve closure. Now, if your mitral valve is, your aortic regurgitation is very, very severe, even before the start of systole, so this is the start of systole, the LV pressure is already higher than aortic pressure, right? So you can also have premature aortic valve opening, okay? First, you can have premature mitral valve closure as the left ventricular pressure is higher than the left atrial pressure. And then you can have premature aortic valve opening as the left ventricular pressure is higher than the aortic pressure. This is a marker of severe aortic regurgitation. So this is premature mitral valve closure, mitral valve closed before the end of diastole. Okay, premature. Then this is premature aortic valve opening. Okay, let me show you. So that is the diastole. All right, that is the opening of the aortic valve. If you notice, aortic valve should only open in systole, but now this aortic valve is open way in the diastolic first. So this is premature diastolic aortic valve opening. So this also significant aortic regurgitation. Okay. So let me give you some tips on aortic regurgitation. Okay, you have to do manual BP as the automatic one might be inaccurate due to wide pulse pressure. So very low diastolic BP might be wrongly detected. What is the marker of bad prognosis? If you see the diastolic BP is less than 70 and the heart rate is more than 60, then your mortality go higher. The linear dimension might not be sufficient to see LV decompensation. So as the dilation is asymmetrical, volume is more effective of remodeling. In 2020 new valvular guideline, the definition of LV decompensation have changed. Before 50% EF. Now EF below 55%, you have to go for aortic valve replacement. Okay, so the rule of 50-50 can no longer be used. Okay, it must be 55-50 now. All right. So this is 37-year-old woman with dyspnea and systolic murmur. What is the diagnosis? Okay, what is the diagnosis here? So what are we looking here? Okay, look at here. So that is, what is that? So this is at systole. Okay, this is anterior mitral valve leaflet. So what is happening? You have an MOD across the anterior, not mitral, pulmonary valve. You have patient with systolic murmur. Okay, it is across the pulmonary valve, and you see this. What is that? If you remember my slides before, this is the flying W sign of pulmonary hypertension. Okay, so this is pulmonary hypertension. You should got that. Flying W sign of pulmonary hypertension. Okay, now I just wanted to show you, this is another example of MOD. So this is an MOD across the interventricular septum. Okay, now our question is, what is happening here? So what is happening in this patient? So this patient have cardiac tamponade and Pulsus paradoxus. How do I know, just looking from this MOD, that this patient have cardiac tamponade? Okay, look at this interventricular septum. Okay, you can see that interventricular septum, sometimes it moves toward the right ventricle, sometimes it moves towards the left ventricle, go towards the right ventricle, and go towards the left ventricle there. Okay, so that is something that is not good. So what is that? That is increased interventricular dependence. Okay, so that is during inspiration, the interventricular septum is going to the left side. Expiration, it go to the right side. Inspiration, it go to the left side, and expiration, it go back to the left to the right side. Okay, so this patient have increased interventricular dependence. So if this patient have pericardial effusion, this is a marker of cardiac tamponade. If this patient have small pericardial effusion or no pericardial effusion, this is a marker of constrictive pericarditis. Okay, remember, in normal people, you will have a little bit of movement of the interventricular septum, but usually you cannot see it in echo. However, in patient with tamponade or constrictive pericarditis, what happened? They have a restriction in terms of the movement of the heart laterally. Because it cannot move laterally, it pushes the septum left and right. So in inspiration, more flow on the left side, more flow on the right side, push the septum towards the left side. So this is what happened here. In expiration, more flow on the left side, it pushed the septum towards the right side. So this is what happened here. Why is that happening? Because there is a restraint by the pericardial fluid in patient with cardiac tamponade. Okay. So this is also the mechanism of Pulsus paradoxus. So what is Pulsus paradoxus? So Pulsus paradoxus mean that during inspiration, there is reduction in systolic BP that is more than 10 millimeter mercury, meaning that you have reduction in your cardiac output. Looking at this now, you can make sense why you have that reduction in cardiac output that is very marked. It is because you can see during inspiration, the septum is moving towards the left ventricle. The cavity of the left ventricle becomes small, so a little bit less flow come out. So that's why you have Pulsus paradoxus. Okay. Remember, in patient with pericardial restraint syndrome, the difference in flow is driven by the changes in the left side of the heart. In normal people, where they don't have pericardial restraint, the changes is brought about by the right side of the heart. Okay. So this is an increase in interventricular dependence due to restraint from pericardial effusion. The variation in flow is driven by dissociated intrathoracic and intracardiac pressure. All right. Now, this is interesting. Look at this M-mode across the aortic valve. Okay. Look at the opening of the aortic valve. This is aortic valve opening normally, slightly smaller, close, opening a little bit big, open, and open. So why is that? This is because during inspiration, so that is during expiration, the aortic valve open. During inspiration, you can see the aortic valve closed because of reduction of cardiac output. So this is also showing you Pulsus paradoxus. Okay, so that is showing you the mechanism of Pulsus paradoxus. This is showing you the hemodynamic sequelae of Pulsus paradoxus that you can see in M-mode. So that's why M-mode is very important. So it is not historical. Right. So this is another M-mode that is popular. So this is a early diastolic collapse of the right ventricle that is suggestive of pericardial tamponade. Okay, so this is systole, aortic valve open. So this is early diastole. You can see collapse of the right ventricular free wall. Right. So now I have shown you the pericardial tamponade. Now let's see constrictive pericarditis. What does the M-mode characteristic of constrictive pericarditis? Number one, you can see the increased interventricular dependent, like I show you in the previous M-mode. Okay. Now, apart from the variation in septal shift, during inspiration, it go to the left, expiration, it go to the right, inspiration, go to the left, expiration, go to the right. There's also another phenomenon that also happen in constrictive pericarditis. This is septal bounce. This is every bit you can see a septal shudder like this at every bit. So why that happen at every bit? So because during diastole, there is a transient increase on the right ventricular pressure, higher on the left ventricular pressure. So this is end diastole. So you can see this is 1. And then after that, you can see it goes here. And then very transiently, the right ventricular pressure is higher than the left ventricular pressure. And you got your this notch here. So you got your shudder like this. Okay, like this at every bit, shudder. Right. So this is 1, 2, 3. So this is septal bounce. Don't confuse that with septal shift. So at early diastole, the RV pressure is transiently higher than the LV pressure. So this is bit-to-bit phenomenon, not to be confused with respirophasic septal shift due to exaggerated interventricular dependence. Right? All right. So this is a 47-year-old female with palpitation. What is the diagnosis? Is this ASD secundum? Is this S-tine abnormally? Is this patient having intra-aortic balloon pump? Does this patient have arrhythmogenic right ventricular dysplasia? All right. Now, what are we seeing here? So, this is the interventricular septum. That is the right ventricle, or this is the left ventricle. Okay, so what happened? The right ventricle is much bigger than the left ventricle. So we have big right ventricle. So what is our differential diagnosis? Is this right-sided pressure overload, or is this right-sided volume overload? Now, because of this is showing right-sided, so we can take out the intra-aortic balloon. So it is not intra-aortic balloon pump. Now, look at the movement of the interventricular septum. Okay, look at the movement during systole and diastole. So look at the diastole. Diastole, the septum is flat. The systole, the septum is rounded. Diastole, the septum is flat. Systole, the septum is rounded. So what is this? So whenever you have diastolic flattening of the interventricular septum, so that is right-sided volume overload. That is right-sided volume overload. So you have a right-sided volume overload. So which one of these cause right-sided overload? So it can either be Epstein anomaly or secundum ASD. So which one of these is the answer? Now the answer is, look at this tricuspid valve leaflet here. So this is anterior tricuspid valve leaflet. Look how long is that anterior tricuspid valve leaflet. It's very long compared to the length of the anterior mitral valve leaflet, compared to the length of the anterior mitral valve leaflet, the tricuspid valve leaflet. So this is very long. So we know that elongated tricuspid valve leaflet anterior happen in what situation? It happened in Epstein anomaly. Okay, so this is a patient with Epstein anomaly. So this is paradoxical septal motion due to RV volume overload. So this is elongated anterior tricuspid valve leaflet. Okay, so show you another M-mode. Okay, so this is one of the most difficult M-mode to understand. Okay, now you remember or not? Those of you who do emergency department, you can always talk about left bundle branch block. Okay, so what is left bundle branch block? So left bundle branch block is electrical desynchrony. Correct? This is an electrical desynchrony. So the left ventricle is depolarized later than the right ventricle. So the impulse go to the right side before go to the left side. Okay. However, this can also affect the heart muscle. So if only affect the ECG, we call it electrical desynchrony. But it will also affect the heart muscle, we call it electromechanical desynchrony. Okay. Now, those with electromechanical synchrony, meaning that there is desynchrony in the ECG, there is desynchrony in the ventricle, might respond better to resynchronization therapy. Okay, I might be wrong. Kokowe can tell. Right. So, but what do I mean by mechanical dissociation? So it is best seen by M-mode. Okay. So in patient with left bundle branch block, in order to understand it, okay, so I just do the very crude picture. All right. So let's say this is a septum, and this is lateral wall. So in patient with electrical dissociation and mechanical dissociation, what happens is you will have a septum that is activated too early. Okay, the septum that is activated too early. All right, you have the lateral wall that is activated too late. So what happened when this is activated too early during systole and this is activated too late? So what happened is that you see a phenomenon in echo that is called a septal flash. So during systole, very early, you can see that the septum is contracting way too early. Okay, and you also see apical rocking. You can see the movement of the apex go from here to here. Okay, so you see apex move like this. Okay, and you can see septal flash. So that is the LBB appearance in the left ventricle if you see in 2D. What do you see in M-mode? So the M-mode is actually very interesting. Okay, and in fact, this is how you tell dysynchrony from M-mode. So look at this interventricular septum. Look at this. This is septum. The septum contract way too early. Okay, this is very, very early in systole. It shouldn't contract yet like this. So this is what we call the septal flash. Okay. Now look at this lateral wall. This should contract somewhere here, but this lateral wall is doing the things quite late. Okay. This is the lateral wall that is contracting late. This is septal flash. This is lag contraction of the lateral wall. So therefore you have the rocking of the left ventricle and the septal flash. Now this is not an efficient way to eject blood. So why is this not an efficient way to eject blood? This is contracting during the isovolumetric contraction time. And you know during isovolumetric contraction time, aortic valve leaflet is not open. So you are contracting nothing. Okay, nothing is coming up. And this is isovolumetric relaxation time. You're also contracting against closed aortic valve. So this is also useless. So therefore, you waste a lot of energy, but you don't reap any rewards. Okay, so that's why bundle branch block is not good. Okay, that's why people EP put a CRT for this patient. Another thing that you can see, just after systole, it's supposed to go like this. Okay, but it doesn't. It's flat like that. Okay, so there is a flattening during systole, the movement of the interventricular septum. So that is also marker of left bundle branch block in echocardiogram. Okay, so you have the septal flash here, or what we call a dip, a systolic dip here, and you have the flattening of the movement here, right? So septal flash with beaking at LBBB. So the combination of early septal activation with late basal infralateral activation can cause the appearance of septal flash with apical rocking. Like, look at the other question. So this is a 42 years old female with mitral stenosis. The Doppler angle interaction of subnormal. What will this do to pressure half time? Okay, so this is actually very interesting. I do not know what is the rationale, but apparently doesn't matter where is your angle of insonation, it will not affect the pulmonary valve, the mitral valve area calculation by pressure half time. Okay, so what I mean to say is, doesn't matter what is the angle of insonation, your pressure half time will not be affected. I don't know what is the rationale behind that. I just wanted to tell you. Okay, look at this. So this is a Doppler across the aortic valve. This is the Doppler across the, this is an M-mode across the aortic valve leaflet. So Doppler across the aortic valve, M-mode across the aortic valve leaflet. So what is your diagnosis in this situation? Okay, let's go one by one. Look at the Doppler profile. This does not look like dynamic LVOT obstruction. Why? Because dynamic LVOT obstruction, it should be late peaking. Okay, so that is not dynamic LVOT obstruction. So whenever you see a parabolic like this must be a fixed obstruction. Okay, this cannot be mitral regurgitation. Why is this not mitral regurgitation? Because you see the flow, it doesn't involve the isovolumetric relaxation and isovolumetric contraction time. Okay, so this cannot be a mitral regurgitation. So this is a flow across aortic valve. It is not a dynamic LVOT obstruction, rather it is a fixed obstruction. So why? Is it aortic stenosis or is it something else? Okay, the clue is looking at the M-mode. You know, look at this. There is a very early closure of the aortic valve, early closure. Just now in patient with HOCM, you can see a mid-systolic closure. This is a very early closure of the aortic valve leaflet. So this is subaortic stenosis or subaortic membrane. Okay, how do I know that this is subaortic membrane? One, this does not look like a dynamic LVOT obstruction. Two, very early closure of the aortic valve leaflet. Number three, remember I tell you, look at this fluttering of the anterior mitral valve leaflet. Okay, look at the fluttering of the anterior, not anterior aortic valve leaflet. You can see fluttering of the anterior aortic valve leaflet. Okay, remember, a calcified leaflet cannot move. So how can they be fluttering? Okay, the only way is fluttering if it's thin. So therefore, the obstruction is at the level of below the aortic valve leaflet. Okay, so this is a subaortic stenosis. All right, remember this. All right, now I wanted to ask you to estimate the LVOT gradient using MR peak velocity. Okay, so I wanted to give you some tips. Now let's say you are measuring the velocity or the obstruction across the left ventricular outflow tract. Let's say you are confused. Is this a mitral valve? Is it correct or not correct? How can you double check? Okay, now the way to double check is actually very easy. Number one, you remember normally your LA pressure, it is not very high, it is not very low. So you can estimate your LA pressure. Okay. Now, let's say this patient have dynamic LVOT obstruction. LA pressure, we just take for the sake of argument, okay, as 15 millimeter mercury. So LA pressure, you always have to guess. Okay. So let's say in this patient, the LA pressure is 15 millimeter mercury. Can we estimate the obstruction across the LVOT without measuring the LVOT Doppler? Yes. What you do is you can just use the Doppler across the mitral valve. So let's say you put your continuous wave Doppler there, okay? And then you got a Doppler profile like this. So you're confident that this is a mitral valve because it is fulfilling the isovolumetric contraction and isovolumetric relaxation time, okay? Then you get that peak velocity across the mitral valve, okay? Now, the peak velocity across mitral valve, you plug into account equation for V squared. So you got that gradient. Okay. So in this situation, what is the gradient? The gradient of the mitral valve is 5.9 meter per second. Okay. So what is the gradient across the mitral valve? So the gradient across the mitral valve is V squared, which is 5.9 times 5.9 times 4. So that is 139.24. So you know that the gradient between the LV and the LA is 139.24 millimeter mercury. Right? Now, you know that that is the gradient. Okay? The gradient between LV and LA is 139 millimeter mercury. Right? Now, what is LV systolic pressure? So LV systolic pressure is 139 plus 15 millimeter mercury. Okay? So 139 plus 15 is 154. Now, since we already know that the systolic BP from our aortic measurement is 120, we can just minus 154 minus 120, so we get 34 millimeter mercury. So we can check that with our measurement of the LVOT. Is it about the same? If it's about the same, then your LVOT measurement is correct. Okay? Now, I tell you one more time, look at this. So this patient have dynamic LVOT obstruction. Now, let's say you measure the LVOT obstruction, but you are not quite sure, is it correct or not? The patient also have MR. So what do? So you use that MR velocity as your advantage, okay? You know that LA pressure you can estimate as 15 millimeter mercury. So you know that LV systolic pressure minus LA pressure is this 4V squared of the MR, okay? Now, so the 4V squared of the MR is 139. So you know that the LV systolic pressure minus LA pressure equal to 139. So LV systolic pressure, LV systolic pressure is 15 plus 139, which is 154. Since you already got 154, you also know your aortic systolic pressure is 120. You can just minus 154 minus 120, so you got 34 millimeter mercury. So that is your dynamic LVOT obstruction. Okay. So I wanted to give you a tips. Okay, I think this is very important of how I measure dynamic LVOT obstruction and how I wanted to make sure that I am doing it correctly. So what I do, number one. So number one is I do straight away continuous wave Doppler of the mitral regurgitation. So what I wanted to know is I wanted to see that peak velocity. Okay, so I just go at the mitral valve and straight away I want to see what is the peak velocity and how is the shape of the parabolic. Okay, that is the first thing that I will do. Second, after I do that, all right, I do pulse wave at this level of obstruction. So I try to do pulse wave at the level of obstruction. Okay, I look at it. Once it's aliasing, so what is aliasing? Aliasing means that it cannot fulfill the whole of the image. Then I know that I am at the level of obstruction. I change to continuous wave Doppler. So my second way is I go here. I go here and go use my continuous wave Doppler. Now, that one, I will see something like this. Okay, dagger shape maybe. Okay, this is a bit wrong, but so how do I know it is correct? Number one, I differentiate. So this shape should be different from this shape that it begin with. That is number one that I know that is correct. Number two, look at the peak velocity here. It should be lower than peak velocity here. Okay, then I know that I'm not measuring the mitral valve. Number two, when I look at CW, I make sure that it doesn't encompass the isovolumic contraction and isovolumetric relaxation time. Okay, so that is how I make sure that I'm measuring the correct LVOT obstruction. So compare the CW of LVOT and the MR, it should be different. The peak velocity is different, the MR jet is also different. So you can check the LVOT obstruction using the calculation that I show you. LV systolic pressure minus LAP equal to MR peak gradient. LV systolic pressure is equal to MR peak gradient plus LA pressure. Obstruction is equal to LV systolic pressure minus systolic aortic pressure. If you want to know what is the shape, you can see in this example here. This is mitral regurgitation. Now you can see the mitral regurgitation also fulfill isovolumetric relaxation and isovolumetric contraction. And this is a true dynamic LVOT obstruction. And dynamic LVOT obstruction is always lower than the mitral regurgitation jet. Okay. All right, so let's show this example here, right? So you have a 34 years old patient with hypertrophic cardiomyopathy and dynamic LVOT obstruction, okay? Come to see doctors. So he had a big meal and also alcohol before meeting the doctors. So what do you think happened to what is the effect of having a big meal and having an alcohol on dynamic LVOT obstruction? Does it make it higher or does it make it lower? Okay, now the answer is it make it higher. Okay, it make it higher. So why does it make it higher? Number one, when you take alcohol and you take a big meal, this will cause vasodilation because the blood wanted to be redirected to the splanchnic circulation. So vasodilation will reduce the afterload. Okay, I give you a tip for dynamic LVOT obstruction in HOCM. Anything that reduce preload or reduce afterload will make it worse. Anything that increase preload or increase afterload will make it better. That's why in patient with HOCM, we do not over diurese them, because when you over diurese them, it reduce their preload and cause increase in their obstruction. We want to give them beta blocker. Why we want to give them beta blocker? Because we want to increase the preload and reduce the filling time. If let's say patient have acute dynamic LVOT obstruction, we give IV fluid because we want to increase the preload. We don't put in IABP because IABP will worsen dynamic LVOT obstruction. Again, the tips for you. Okay, obstruction will get worse with reduction in afterload and reduction in preload. It will get better with increase in preload and increase in afterload. Okay. So reduce afterload and reduce preload will both increase the degree of obstruction. Okay, so this is an example of someone. All right, so this is someone with dynamic LVOT obstruction. So what we do is we use the mitral regurgitation as our marker to calculate whether our LVOT obstruction calculation is correct or not. Okay, so let's say you have a patient with HOCM. You know that the patient have a big obstruction and suddenly they come to your office and then the obstruction is become less. Ask them to go out and ask them to makan and take alcohol, or no, don't take alcohol, just makan only, and then come back to see you in clinic. Then the obstruction will become worse. Okay. So if I say the LAP is 15 millimeter mercury, you can actually recalculate yourself to see whether the LVOT obstruction is correct or not. Okay. All right. Now, what about this one? Okay. I have teach you in prior slide what is the answer for this. So what is this going on? Okay, so this is an end mode across aortic valve. When does this end mode close? This is a mid-systolic closure of the aortic valve. Early systolic closure is subaortic stenosis. Mid-systolic closure is dynamic LVOT obstruction. Okay, what are the clue that this is not aortic valve leaflet, but below there is fluttering of the aortic valve leaflet. So this cannot be problem with the aortic valve leaflet. Okay. Now, what about this second end mode? So this is an interventricular septum. Look at this. What is that? You have a septal bounce. All right. So this patient have septal bounce at every beat. So this is a constrictive pericarditis. Okay. The neck vein also shows a rapid X descent. Remember, Anderson, Cooper, Love, Van der Witt, Yale. X descent is early systole when the atrial is relaxing. And Y descent is early diastole. In patient with constrictive pericarditis, at early diastole, the blood rushing from the left atrium to the left ventricle. Therefore, you get this rapid Y descent. Okay. So what about this one? Okay. Now, if you remember, look at this interventricular septum. What do you see here? You can see a diastolic beak here. Okay, so I wanted to show you in this example someone with left bundle branch block and electromechanical dissociation, and someone with left bundle branch block without electromechanical dissociation. Okay, you can see in this situation the patient have that septal flash. Okay, the patient also have late activation of posterior lateral wall. However, in this true electromechanical dissociation, there is flat movement at diastole. In this patient, even though the patient does have this diastolic beaking, but you can see that during systole, there is still movement towards the left ventricle of the interventricular septum. Okay, so this is not a typical electromechanical dissociation. This is a typical electromechanical dissociation. So let's look at the next one. Okay, so what is the diagnosis for this one? So I just wanted to show you that this is a patient with pericardial effusion and a swinging heart. So large pericardial effusion and a swinging heart. So how do I know this patient has swinging heart? So the way I know is like this. Look at the septum. The septum is moving towards the right, towards the left, towards the right, towards the left. Now you will tell me that, oh doctor, this can be interventricular dependence because of pericardial tamponade. Yes, but this is also the movement of the heart swinging from the left to right. How do I know that? Because you can see the mitral valve also follow the movement. You can see the mitral valve go down, go up, go down, go up. Okay, so the heart, so if you have a big pericardial effusion, the heart will move like this, like a swinging heart. So as it go near to the heart wall, it go back, it go near, it go back. So this is also the basis of electrical alternance that you have in pericardial tamponade. Big QRS, small QRS, big QRS, small QRS. Okay. Right. So what about this one? So this is also the same. Okay. Again, I wanted to show you left bundle branch block. Okay. So you look at A. So A is your typical left bundle branch block. This is the septal flash. Okay. It's too early contraction of the interventricular septum. This is a contraction of the basal inferolateral wall that is too late. This is a diastolic that is very flat. Okay. So this is not good. What about the second one? So this is a patient with left bundle branch block, but doesn't have the typical electromechanical dissociation. You can see that the period during diastole, it is not so flat. There is a little bit of movement here. All right. So this is actually a patient that does not have electromechanical dissociation at all. So this patient also have a little bit of diastolic beaking, but you can see that interventricular septum is actually moving normally. So as basal inferolateral wall. So this and this move at the same way, just like normal people. So this is a typical electromechanical dissociation. This is a typical LBBB that might respond to CRT. This atypical LBBB. This is a completely dissociated LBBB and mechanical. It doesn't follow at all. Okay, this won't respond to CRTD. All right. So what about this picture here? What is the difference between this one and this one? So you look at this. This look rectangular. Whenever it's rectangular, think about aortic valve. So you can see this aortic valve is opening. So what is the difference between this and this? So basically, you can see that the distance has gone down from 1.8 to 1.0 centimeter. So it has opened less, okay? But the closure is correct. It is not an early closure, not like subaortic stenosis, not like dynamic LVOT obstruction, okay? Furthermore, you can see that the leaflet is thickened. Okay, this is aortic stenosis. So this is a normal aortic stenosis across the aortic valve leaflet. So you can see the leaflet that is thickened and the leaflet that is thickened. You can see that the excursion has come down, but the closure is still normal. And you don't see fluttering on the leaflet. Okay, you cannot see fluttering of the leaflet. So this is calcified aortic stenosis. Right. Now, this is a patient that have exaggerated interventricular dependence. So this patient presents to you. When you look at the echocardiogram, right, you can see the septum going to the left in inspiration, to the right in expiration, to the left in inspiration, to the right in expiration. But when you look at the tissue Doppler is normal. Okay. When you look at the hepatic vein is normal. Okay. So what is happening here? All right. there is just this exaggerated interventricular dependence, a respiratory variation, without other sign of constrictive pericarditis or tamponade. So what are we dealing with? So remember or not, I told you, in patient with pericardial restraint, it is the left part of the heart that is driven the right side of the heart. Okay, so in patient with tamponade or constrictive pericarditis, you can see variation in the flow of the blood from the pulmonary vein to the left atrium, but you don't show a variation from the SVC to the right atrium. Okay, but in this patient, if you notice, during inspiration, there is a lot of flow from the SVC to the right atrium. During expiration, there is less flow from the SVC to the right atrium. What is happening? It seems that the right side is driving the left side. Okay, so this is actually a normal patient. But how come this patient have exaggerated interventricular dependence? So another way to have exaggerated interventricular dependence is someone that is in respiratory distress because of increase in respiratory effort. So they're breathing like this. So because they're breathing like that, they have increase in interventricular dependence. But this is bringing from the right side. How do I know this? The patient does not have other characteristic of constrictive pericarditis. Furthermore, it is the right flow from the SVC to the right atrium that is varying with respiration compared to the left side. Okay, so this is a SVC profile flow from an elderly man with shortness of breath. So this is patient with COPD or someone with respiratory distress, not someone because of constrictive pericarditis or pericardial tamponade. All right, this is a spot diagnosis. Let's say you have a continuous wave Doppler at the middle of left ventricle and it shows flow during systole and also flow during diastole like this. So what is the diagnosis? Okay, so this is almost pathognomonic, meaning this is a almost diagnosis of someone with apical hypertrophic cardiomyopathy with apical aneurysm. Apical hypertrophic cardiomyopathy with apical aneurysm. So what is happening? So what is happening during systole, there is some flow down. Now, during diastole, the aneurysm recoil and also push the blood flow towards the base of the left ventricle. So you have a flow during systole and you have a flow during diastole. So this is apical hypertrophic cardiomyopathy with aneurysm, right? So we got I think got 4 or 5 cases left. Right? Apical HOCM with aneurysm. All right. So what about this one? Okay, so what is this, right? You can see in this patient, you have D point, E point, F point, A point, C point, but there is something in between A and C. There is something between A and C. There is something. So there is something there. So what is that? Right. So that is B bump. B bump. So what is B bump? B bump is a very specific marker for increased left ventricular and diastolic pressure. So that is how useful is MOT. Okay, so if you have someone with a diastolic function that you cannot interpret or is very complex and you don't have any characteristic as a tiebreaker, B bump is very useful. B bump is actually almost 100% certainty that you have increase in left ventricular and diastolic pressure. So this is actually a B bump. Remember, you only have supposed to have D, E, F, A, C, but suddenly you have a B in the middle. Okay. What about this one? I've shown you before, just repetition for perfection. So this is a mid-systolic closure of the aortic valve. The aortic is fluttering. So this is dynamic LVOT obstruction. This is a very early closure of the aortic valve, also fluttering. So this is a sub-aortic stenosis. All right. So what about this one? I already showed you before. This is a normal pulmonary valve appearance in MOT. You can see the atrial contribution to the pulmonary leaflet movement. And then this is a normal movement of the pulmonary valve. This is the flying W sign of pulmonary hypertension. Right? What about this one? Okay. Remember, I told you during diastole. You see what happened during diastole? You have one diastole, and then suddenly the right ventricular pressure is higher than the left ventricle. You have another bump here. So what is that? That is diastolic septal bumps that happen in constrictive pericarditis. Okay. Now, what happened here? So this is after they do pericardiectomy. You have stripped the pericardium. You can see there is no longer diastolic septal bumps. All right. Okay. Last 3 cases. So what about this one? Okay. This is left atrium. This is the left ventricle, this is aorta. So I just bagi you bonus case. This is interesting. You can see that the aorta is overriding the right ventricle and left ventricle. Okay, so this can be tetralogy of Fallot. However, this patient does not have any output from the right ventricle. This is the only valve that coming out from both the left and right ventricle. So if this is the only valve that come out from the left and right ventricle, what is that? That is truncus arteriosus. Okay, that is truncus arteriosus. Remember, when you have a malaligned VSD like this, so the VSD by definition is at outlet VSD. So if you look at the picture, all the flow going to single truncus vas, and later pulmonary valve will come out from that truncal valve. Okay, so that is truncus arteriosus. Then you have your type, Collet-Edwards, type A, type B, type C, if I'm not mistaken. Okay, now you can see here. So this is the blood going into the aortic valve. So this is actually the pulmonary, and that is aorta. The going to the zone, but this is the single tricuspid valve. Tricuspid valve, the most common, it is quadricuspid deflect. Okay, right, that's truncal valve there. This is truncus arteriosus. Right. So what about this one? Okay, this is very interesting. So every time you see someone, right, you see echo or someone in parasternal long axis view, look at the great vessel. So the great vessel is actually parallel. No, you can never see a parallel great vessel in normal human. Okay, so this can only happen in patient with congenital heart disease. Okay, you can see in this patient, this is the pulmonary valve, this is the aortic valve. It's actually have changed place. The pulmonary valve is actually coming from the left ventricle, and the aortic valve is coming from the right ventricle. Okay, how do I know it is the great vessel that is changing, not the ventricle? It is because there is preservation of the mitral aortic curtain. This is preservation of the mitral pulmonary curtain in this situation. Okay, so aorta is at the front, pulmonary is at the back. It is actually coming from different ventricles. So this is a transposition of great artery. What type of transposition of great artery? It is a detransposition of great artery. Okay, because the great vessel that is changed side. Now, if you look, so that is the preservation of the continuity. Okay, so both vessel parallel enrichment. Right. So if you look at the short axis view, in short axis view, in normal people, the pulmonary and aortic valve cannot be seen en face together. Okay, you cannot see both at en face, but this one you see en face. Okay, this is aortic valve and this is pulmonary valve. So aortic valve is anterior and to the right of pulmonary valve. So that is a characteristic of transposition of great artery, of detransposition of great artery. Okay. All right, so you can also see that the patient have right ventricular enlargement, right? Now, so what do we have in detransposition in great artery? So in DTGA, you have ventricular arterial discordant. So the arterial change place. The LV go to the pulmonary artery, the RV go to the aorta. How do you differentiate DTGA and CTGA? With DTGA and LTGA, with DTGA, you die at born if you don't go for operation. This is not consistent with life unless you go operation at birth. Okay. In CTGA, you can wait if let's say the patient does not have other lesion. The aorta come out from the morphologic right ventricle and pulmonary come out from the morphologic left ventricle. This arrangement is incompatible with life. Okay, at birth, usually you enlarge an ASD to make the blood mix in. You do Rashkin septostomy. Now, few days after birth, usually we do the complete correction. The name of the complete correction is Jatin procedure. What do? We change the place of the pulmonary. We go to the aorta, aorta to the pulmonary, and we cut on the sinotubular junction. Okay. Prior to 1980s, they don't do Jatin procedure. They do what we call a mustard and sanding procedure, in which they baffle the blood from the right to the left and to the left to the right. I will show you a little bit later. What if someone got DTGA, ventricular septal defect, pulmonary stenosis, and left ventricular outflow tract obstruction? So this is a bit complicated. If the pulmonary valve is good size and comparable to aorta, you do arterial switch and close the VSD. If the pulmonary valve is mildly stenotic, you do a Nikaido procedure, which is aortic translocation. You take the aortic with the root itself and transplant into the left ventricle, and then bring the pulmonary artery to the right side and connect to the right ventricle. If the pulmonary valve is small, we do a Rastelli. What is Rastelli? Rastelli is when you baffle the left ventricle to the aorta through the VSD and you put the RV to pulmonary artery conduit. Historically, Rastelli is the first surgical correction done for DTGA. This is very tragic. Rastelli is a surgeon in Mayo Clinic. He died at the age of 37. So just wanted to show you an arterial switch procedure. So what is arterial switch procedure? Pulmonary artery coming from the left ventricle and aorta coming from the right ventricle. That is not good. Okay, that should not happen. So what they do is they transect the pulmonary artery and they transect the aorta. Okay, they bring the aorta back and put on top of this pulmonary artery. This pulmonary artery back and go on top of the aorta. They transfer the coronary from here to here so that this will become a neo-aortic route connecting to the aorta. This will become a neo-pulmonary route connecting to the pulmonary artery. So this is arterial switch procedure, Jatin procedure. So this is the end product. Okay, this is the pulmonary artery that has been transferred. That is aorta that has been transferred. That's what we call a Lecombe maneuver, and that is how you see the Lecombe maneuver in cardiac MRI. Okay, so this is unique arrangement that is only seen after Lecombe maneuver for Jatin, and this is a neo-aortic route with risk of aneurysm and regurgitation. All right. So I just wanted to give you, so I just go quickly. So this patient have left ventricular dilatation. Okay. That's the pulmonary artery there. Okay. And then we see here the LV is dilated. Okay. We need to find the reason why the left ventricle is dilated. So you can see the pulmonary artery is also dilated. And then you can see a continuous flow from the descending. This is a descending aorta. This is a pulmonary artery. You can see a continuous flow from the descending aorta to the pulmonary artery. So whenever you see a continuous flow, whenever you see a continuous murmur, what is your differential diagnosis for continuous murmur? Sinus or vasa valve rupture, coronary artery fistula, Blalock toxic shunt, and pattern ductus arteriosus. So what is this? So this is pattern ductus arteriosus. You have a connection between the descending aorta and the pulmonary artery. Okay, pulmonary artery. All right, and this is a Doppler that you have to always remember. So this is a favorite question in EchoBot. So whenever you see a Doppler like this in the descending aorta, so this is a pattern ductus arteriosus. Okay, when you put at the connection of descending aorta to the pulmonary artery. So the most likely diagnosis for this is, now SOV rupture can cause continuous murmur, but this is not sinus vasa valve rupture. Large VSD, usually a systolic murmur. Anomalous LAD from right sinus don't give murmur unless it's have a fistulous communication. So this is a PDA, large pattern ductus arteriosus. All right. So what about this one? So this is just to differentiate DTGA from LTGA. So this is L transposition of great artery. How do I know this is L transposition of great artery? You can see that this curtain here from mitral to this one, there is no longer continuous. You can see a big mass here separating them. So this is a discontinuity. So this is LTGA. DTGA, the great artery that is changing side. In LTGA, it is the ventricle that is changing side. Okay. All right. You can see here, this is supposed to be left ventricle. This is supposed to be right ventricle. But you see something very wrong. How come on the right side, the leaflet is more apically attached? This looks like a tricuspid valve because so this must be the right ventricle on the left side. So further telling you that this is L transposition of great artery. Okay, more apical, AV attachment on the left side. Okay. And you can see on fast view. Okay, this is aorta anterior and to the left, this is pulmonary artery. So if you see aorta anterior and to the left, that is usually LTGA. If you see aorta anterior and to the right, that is detransposition of great artery. Okay. So this is, whenever you have LTGA, you have atrioventricular and also ventriculo-arterial discordance. What is the salience point of LTGA? So the main issue is both atrioventricular and ventriculo-arterial discordant. This double discordant allow normal blood flow in series. So in LTGA, you don't need operation at birth because this is actually consistent with life. The arrangement, if you look at pediatric arrangement, it is SLL. S meaning it is situs solitus. L meaning it is L-loop ventricle, the ventricle change side. And L at the end is aorta is transposed at the anterior and to the left. Okay, very rare it can be IDD, in which you have situs inversus, D loop, and aorta is D transpose, but this is very rare. Okay, just understand the nomenclature of pediatrics. So even though the blood flow is normal, the systemic ventricle is the right ventricle causing development of premature heart failure. If there is pulmonary stenosis, usually they will undergo intervention to relieve the obstruction. Rarely, the patient can go through double switch procedure or switch Rastelli procedure if concomitant VSD and PS for anatomy and physiological correction. And the other option is to opt for Fontan, which is a single ventricle pathway, right? So just wanted to show you someone with a double switch procedure, okay? You can see they reroute the SVC flow to the left ventricle. They route the pulmonary vein flow to the left ventricle, all right? And then they change the aorta to the pulmonary artery and pulmonary artery to the aorta, right? So you have this double switch procedure here, right? Now, if you want to put a pacemaker, you can. You just go to the SVC, then you attach one on the morphological left atrium, and for the lead you put in the morphological right ventricle. All right, so I just I don't realize that it's going to be this long. Okay, so sorry about that. All right, I just wanted to show you quickly. So this is example of someone with unroofed coronary sinus. So in patient with unroofed coronary sinus, this is where you see the dilated coronary sinus. Okay, see, you can see the dilated coronary sinus. When you put agitated saline on the left brachial vein, the agitated saline will go through the persistent left superior vena cava into the dilated coronary sinus. If the CS is unroofed, it also will go into the left atrium. Now, if there is persistent left SVC without unroofed CS, there will be no bubble on the left side of the heart. It will only go on the right side of the heart. Okay. So one more time, you put a bubble into the left brachial vein. The bubble go into persistent left SVC, then go into the left coronary sinus. Because it is unroofed, it also go to the left atrium and left ventricle. This is how we diagnose unroofed coronary sinus atrial septal defect. Salient points on unroofed CS. So the CS run on top of LA posterior wall. Contrary to previous belief, they don't actually have a shared wall. Both have their own separate wall. Clue to the presence of unroofed CS is dilated CS with absence part of its wall and flow going into LA. As unroofed CS is frequently associated with persistent left SVC, the way to diagnose is by injecting agitated saline into the left brachial vein. The bubble will appear in the coronary sinus, then into the LA-LV and the RA-RV if it is indeed unroofed. If the bubble is injected into the right hand, bubble will actually seen first in RA before going to the CS and left atrium. Right. Now, this is someone with sinus venosus ASD. Okay, what is the reason I show you? Because this is the thing that you see very, very rarely. Okay, what is sinus venosus ASD? It is deficient in wall between either superior vena cava or much less commonly IVC and the left atrium. Now, this is actually very interesting. This is actually a transthoracic view where you go subcostal. You can actually see bicaval. What is bicaval? So this is IVC. This is SVC, this is right atrium, that is left atrium there. You see there is a defect here that divide the SVC wall and the left atrium. So this is a superior sinus venosus ASD. The arrow there showing the defect between the left atrium and the right atrium. IVC, SVC, and sinus venosus ASD. Okay, sinus venosus. If let's say in TEE, it's much more clear. Okay, I show you in TEE. So this is in TEE, right? So you can see there is a defect here. This is the wall that is shared between the SVC, left atrium. So this wall is deficient. So therefore, if you have a blood that go into the SVC, it might go straight away into the left atrium via this communication here. Okay. Now you can also have anomalous pulmonary vein that should drain into the left atrium, but they drain into the SVC here. All right. If you want to tell me, oh, is it a sinus venosus or is it a secondary ASD? Remember, you can see the limbus of the interatrial septum, and this defect is after the limbus of the interatrial septum. Okay, so this is an example of superior sinus venosus ASD, and you can see the whole of the superior sinus venosus ASD here, and you can see the anomalous right upper and right lower pulmonary vein here. So during repair, the surgeon will cover both of these. They will reroute the flow from the pulmonary vein back into the hole, back into the left atrium. That is called the Warden procedure. Okay, so this is your fossa ovalis. What is a salient point on sinus venosus ASD? Superior sinus venosus ASD is far more common compared to inferior sinus venosus ASD. The most difficult ASD to visualize in TTE. The defect is usually very posterior, and the only clue sometimes is unexplained RV dilatation. Sinus venosus ASD almost invariably is associated with anomalous return of the right pulmonary vein into the SVC, and the operation done to repair this defect is the Warden procedure. All right, so just last two cases, so bear with me. So I don't know how much of you left, so maybe just 1% or even 0. So maybe I'm talking to myself now. So this is someone with left bundle branch block, okay? Now, if you look at E over A is 0.7, okay? You look at medial E prime is 3, and lateral E prime is 9. Now, if you're thinking about constrictive pericarditis, you will be suspicious because I teach you that in constrictive pericarditis, the E prime should be much higher than this, and the E prime should be higher than lateral E prime. So the patient should have annulus paradoxus and annulus reversus, okay? Now, when we look at this patient interventricular septum, you can see that during inspiration, the interventricular septum actually goes towards the left side. And during expiration, it goes towards the right side. So this is consistent with exaggerated interventricular dependence. So you have 1 point for constrictive pericarditis. Now, looking at the pulmonary vein Doppler, it looks normal, does not look that the patient has significant diastolic dysfunction. And the TR jet is also doesn't go into that threshold of significant diastolic dysfunction. Now you look at this interventricular septum, okay? And then I put a line in the interventricular septum, okay? You can see the septum sometimes move to the left side on inspiration. So that's expiration, inspiration, expiration again, inspiration, expiration, okay? So you can see there is exaggerated interventricular septum, all right? So you ask yourself, can this still be constrictive pericarditis with that reduced septal E prime? Yes. So this is a special situation in which this patient have left bundle branch block. This is in patient with left bundle branch block because the septum is affected. It is possible to you to have a reduced E prime there, even though you have constrictive pericarditis. So this patient, his diagnosis is constrictive pericarditis. Furthermore, the patient have rapid X and I descent. Remember, Anderson, Cooper, Love, Van der Weydt, Yale. Okay, remember the mnemonic. So the clinical presentation with rapid X and Y descent and right heart failure points towards constrictive pericarditis. The patient have LBBB. Therefore, the tissue Doppler is not reliable. No annulus reversus, as in LBBB, the lateral annular velocity is elevated and the medial velocity is depressed. However, brought from the M-mode and 2D echo, we can see that there is marked respiratory variation due to exaggerated interventricular dependence. The TR max velocity and the pulmonary vein Doppler does not point towards diastolic dysfunction. So this is a 23-year-old with HOCM. Okay, what is your diastolic grade? Okay, it's very easy. If you look at the algorithm, this patient already have myocardial disease. So you skip straight to algorithm number 2 and look at the EA. So the E over A is 2.3. So this is straight away grade 3 diastolic dysfunction. Okay. So this patient with ischemic cardiomyopathy, all right? So this is also the same. The patient have myocardial disease. You don't need to go to algorithm 1. You straight go to algorithm 2. And your E over A, your E is 45. E over A is less than 0.5, less than 0.8. So this is grade 1 diastolic dysfunction. The patient have normal filling pressure, all right? So thank you very much, everyone, for joining me on this very, very long lecture. I don't expect it to be this long, But if you think it is very fast, I advise you before your exam, like 2 or 3 days, just look at this lecture again. I'm sure there will be questions that come from this lecture. Okay, so the final words, there is massive advantage of MMOD is the temporal resolution, capturing fast-moving object. The frame rate for MMOD is 1,500 to 2,000 frames per second. For 2D, it's only 60, 70 frames per second. MMOD is useful and easy to remember. It is a low-hanging fruit in exam. Remember all the MMOD that you see in this lecture and you will have 3 points in exam. Ditto spectral Doppler. Even one spectral Doppler can be diagnostic. And lastly, a day or two before exam, watch this video. Thank you very much. So is there any question? Is there anyone left? Oops.